This is the second, part 2, of the transplantation lecture. Now, all of the preceding, which was in part 1, apply to most transplants. Next, we're going to discuss liver transplant in particular. Now, diseases that are commonly treated with liver transplant are the cholestatic liver disease, chronic hepatocellular diseases, vascular diseases, hepatic failure, inborn metabolic disorders, and primary hepatic malignancies. So how in the world do we select which candidate will receive a new liver? There are some contraindications. One is brain death, and that's, I always say that's kind of a duh. Metastatic malignancies, extrahepatic malignancies, active drug or alcohol abuse, advanced cardiopulmonary disease, AIDS, or sepsis. So in general, you can say liver transplantation is not offered to people who would not likely survive major surgery, because it is a very long major surgery, which is the reason that advanced cardiopulmonary disease patients are generally not transplanted. Would not survive long-term immunosuppression, and that is all the malignancies and the AIDS and the sepsis, because, as you learned from part 1, they're more at risk for infection, and if they have other malignancies within their body, they can actually spread them quicker. Have a disease that is likely to quickly recur and cause death, or who are non-compliant, and that would be the people who may have active or drug or alcohol use, because they probably wouldn't maintain the very rigorous process of taking their medications and follow up with their physicians. Now, relative contraindications include physiologic age. Now remember, chronologic age is not necessarily a contraindication. More important is physiologic age. Advanced renal disease, multiple hepatic malignancies, moderate cardiovascular disease, peripheral vascular disease, or psychosocial factors. Some disease reoccur after transplantation, such as viral hepatitis, sclerosing cholangitis, and biliary malignancies. So to immunosuppress these patients would actually hasten their death. So we also have to look at other factors involved in recipient or candidate evaluation. One is the patient history. Are there risk factors for viral hepatitis? Is there a family history of liver disease? Any chronic disorders such as diabetes? And an in-depth history of the liver disease, past medical history, social history, and status of immunizations, because the immunizations have got to be given before they start the immunosuppressive therapy so that they will take. Now, I want you to look at these lists of lab tests. Liver function profiles, renal function profiles, hematology such as a CBC and a SED rate, thyroid function, serologies for hepatitis and other infections, a blood typing and screening, and immunologic profiles, nutritional profiles, and tumor markers. Remember, we'd send them in for these lab tests. They go in already weak and then come out even weaker, because sometimes, I swear to God, it took like a unit of blood to fill all these lab tests. They also have to have a 24-hour urine. They need stool for ova and parasites and occult blood, because we obviously don't want to unleash a parasitic infection. They want a GI workup, including an endoscopy and a liver biopsy, a pulmonary profile, a chest x-ray and an ultrasound of the liver, and numerous other studies such as a mammogram, because you certainly would want to know if there's any latent cancer, breast cancer, because giving immunosuppressive therapy would just unleash that too. So after all that evaluation is done, there's a team of people who then determines whether that patient can be suitable for a transplant, not suitable for a transplant, or a possible candidate at a future date. They all get around a little table and discuss the patient. Generally, the patient and the family are with them. So, you've decided that this patient is suitable for a transplant. How do you decide whether or not he or she is to be the first one on a list? And what they do is they determine a MELD score, and that stands for Model End-Stage Liver Disease, or ESLD. It is a disease severity scoring system applied to adult liver patients. Now, the MELD score is calculated using a relatively simple formula that relies on 3 readily available objective variables: serum creatinine, total bilirubin, and an INR. So here's that very simple formula, which I'm sure you'll be glad to know that you're not going to have to calculate. However, you should understand what the scores mean. After it's calculated, if the MELD score is less than 24, the patient is considered to be a status 3. It's too early for them to be transplanted. From a score of 24 to 29 is considered a 2B. And they're end-stage liver disease, but they're not in the hospital yet. Anything greater than or equal to 30 is a 2A, and that's end stage. Generally, they're in the ICU. A status 1 is acute liver failure with a survival of less than 7 days. Now, there are pre-transplant phase problems. Hepatic encephalopathy is generally related to the increased ammonia levels, and that is treated with antibiotics and lactulose and dietary control of protein. Coagulopathies, now remember the liver is involved in making all those factors that are involved in the coagulation cascade, must be corrected and the patient monitored for intracranial bleeding. GI hemorrhages can occur because of the portal hypertension and may require a TIPS procedure or placement of a vascular shunt. And we're going to discuss this with the lecture on liver disease. Patients with massive ascites have a total body fluid overload but intravascular depletion, and they require albumin and diuretics and may require paracentesis. I'm going to talk about that again when we look at liver. And there's also a condition called spontaneous bacterial peritonitis, which must be aggressively treated with antibiotics, and the person is temporarily removed from the waiting list until that infection has cleared, and then they're put back on again. Now, determining donor suitability is actually only based on 2 things: blood type and the size of the liver. HLA typing is not necessary in liver transplantation. For what reason, I do not know, because it has not been shown to affect the patient outcome. But the donor liver is screened for infectious diseases, metastatic cancers, and its size. When the liver is harvested, it is infused with a preservation solution, packed in ice, and can be kept there no longer than 12 hours. Now, the surgical procedure is lengthy and difficult and lasts about 4 to 12 hours. During the anesthesia induction, they insert large bore catheters, a pulmonary artery catheter, an arterial line to measure blood pressures, an NG tube, and a Foley catheter. And then the surgery begins, and it has 3 stages. There's the recipient hepatectomy, vascular anastomoses, and biliary anastomoses. And we're going to look at each of these in a bit of detail, not much. This is stage 1, which is removal of the native liver, and that's the liver that's diseased. This is the longest, and it is complicated by coagulopathies, adhesions, portal hypertension, and venous collaterals. And it's during this part of the surgery that the patient is placed on something called a veno-venous bypass. This pump cycles the blood out of the iliac and portal vein cannulas and returns it to central circulation via the axillary or subclavian vein. This actually gives the surgeon a little more time, because when they first did it, it actually was like clipping the circulatory system in half, and the lower extremities would get extremely edematous because there's no way to return the venous blood back up into the heart and lungs to get oxygenated. And when you can't return that blood, the cardiac output would drop, which means they'd have a drop in blood pressure. So they had to be really quick. But when they moved to this veno-venous bypass, it actually gave the surgeons more time and more control over the hemodynamics of the patient. Now, stage 2 is where there's 4 anastomoses that must be completed. One is the suprahepatic vena cava. So both the suprahepatic and the infrahepatic vena cavas must be sutured back together. The hepatic artery and the portal vein. And in stage 3 is where the biliary systems are anastomosed. This is the bile duct anastomoses used for patients with a normal bile duct. The bile system of the new liver is connected to the bile system of the recipient, and a T-tube is placed, and a drainage bag collects the bile until healing occurs, and that drainage bag is going to be on the outside of the body with that T-tube. Now, there's also something called a Roux-en-Y surgery. This is a procedure where the new bile duct system is attached to the jejunum because of the fact that the bile duct system of the patient may have been diseased, such as in biliary atresia or where the bile duct is missing. There is no T-tube place, and it makes it problematic to monitor the graft function. We're going to talk about that a little bit later. Now, this is the post-operative medical and surgical management. The 3 things that they want to do during this immediate post-operative time is to reestablish normal body temperature. They want to stabilize their hemodynamics, which means their blood pressure, and maintain an effective airway. So to reestablish the normal body temperature, they use warming blankets, heating lamps, and head covers because the hypothermia is very common after this surgery. As far as hemodynamic stabilization, the patient may arrive hypertensive or hypotensive. So the nurse must monitor total body fluids, including the arterial blood pressures, pressures within the heart using a Swan-Ganz catheter, urinary output, and all drains. Albumin and/or fresh frozen plasma may be used for replacement fluids. And each transplant center will have specific protocols but the same goal in mind. They want to optimize tissue perfusion, especially for the new graft. Ventilatory support is maintained until the new liver can clear the anesthesia and the patient wakes up. Nursing will draw ABGs and monitor them and use a pulse oximeter. Interventions will include suctioning and bronchodilators. And when the patient is extubated, they are obviously encouraged to cough and deep breathe, as with all post-op patients. Also during this time, they're going to want to correct the electrolyte abnormalities that occur. There are disturbances in potassium and magnesium. If the serum levels of these electrolytes are high, it indicates there is renal impairment, and that occurs a lot of times during this surgery. If levels are low, it can be related to the effects of diuretic therapy. They also must monitor sodium levels because that can complicate the replacement of fluid. As far as coagulopathies go, the nurse must do a careful assessment of the patient for blood loss, such as, are they tachypnic? Are they tachycardic? Do they have poor peripheral oxygenation? So you're going to check their capillary refill. Do they have a sudden increase in abdominal girth, which may mean peritoneal bleeding? Do they have sanguineous output from the NG tube? What are their lab values, especially their hemoglobin and their hematocrit, and the contents of all drains? Now, the caveat to this is reversal of coagulation must be done very judiciously, because if you overcorrect it, it can result in a thrombosis of the new anastomoses and lead to a huge amount of problems. As far as neurologic assessment goes, patients who have had encephalopathy before the transplant will be slow to clear mentally, but should be alert within 1 to 2 days. Immunosuppressant drugs, intracranial bleed, sodium imbalances, and pain meds can actually cause neural changes. Now, renal function, more dysfunction you'd have to say, ranges between 21 to 73% of patients. Some require hemodialysis or ultrafiltration, and with good hepatic function, the renal function usually improves. With the immunosuppressive therapy, it puts the patient at risk for infection. And with biliary drains, the nurse must document the color and character and the amount of drainage. Bile drainage should be golden or light brown in color. As recovery continues, it becomes green, and dark muddy brown means possible ischemia or necrosis. Now, these next couple of slides are the common complications that occur during a liver transplant. Pulmonary complications include pleural effusions, pulmonary edema, pneumothorax, atelectasis, and paralysis of the right diaphragm. Common other ones for biliary, there are leaks, obstruction, and infection or cholangitis, and a breakdown of the anastomoses. And as far as vascular goes, there are all these thromboses, the hepatic artery, the portal vein, and the vena cava. And there also can get line sepsis and hepatic vein thrombosis. So there are a lot of things that can happen to these patients that the nurse must monitor for. So, the patient must be monitored post-transplant for an assessment of hepatic function. We're going to talk about all these things. They also must have surveillance for rejection, and they require long-term follow-up for the rest of their lives. Now, as far as the assessment of hepatic function, all of the liver enzymes, including the AST, ALT, and GGT, will initially rise and then begin to fall, usually by day 3 to 4. The patient with primary graft failure, also known as hyperacute rejection, will have hemodynamic instability, which means their blood pressure is up and down, progressive renal deterioration, coagulation, and abnormal serum liver function tests. They will have hypoglycemia, continued ventilatory needs, and inability to waken from the anesthesia. If the graft continues to be non-functional, meaning that they remain in hyperacute rejection, then the patient will have to be relisted and they will go to the top of that UNOS list. However, if the graft takes, you're going to see improving renal function, mental alertness, you're going to see high to normal glucose levels, they'll get early extubation from the ventilator, and the ALT, AST, GGT that peak on day 3 to 4 will start decreasing thereafter. But the bilirubin may take about a week to decrease. Acute rejection, now remember that involves the T cells, usually occurs between 7 to 14 days after transplant. And what you'll see is an elevation of the liver function test, fever, and a drop in that bile output into the T-tube, into the little bag that's on the outside of the patient, and a change in viscosity and color. Now, late signs include malaise, dark urine, and clay-colored stool. With either a liver biopsy is done to detect rejection and is treated with an increase in immunosuppression. Now, remember, chronic rejection is a humoral event, and that involves those B cells, and it is progressive and non-reversible. So that's why I stress so highly to all of you that these patients must get the correct dosage and they must get it on time. Now, liver transplant needs long-term follow-up because they're at risk for hypertension, renal insufficiency, biliary complications, infections, and malignancies. So they do this by doing a liver biopsy, which we're going to talk about next. Now, the liver biopsy evaluates both liver disease and the condition of the graft. It is performed at the bedside or in an imaging department. Now, the patient should be NPO for 6 hours before the biopsy, and coagulation studies such as PT-PTT should be done and corrected prior to the procedure. Now, the procedure involves the pericapsular liver tissue to be anesthetized, and then they take a coring needle and place it between the 8th and 9th intercostal spaces while the patient holds their breath after exhalation. A sample of the liver tissue is withdrawn and then they apply pressure. Now, what you need to teach the patient is that during the procedure there may be some pain and pressure, and the pain may radiate to the right shoulder, and they need to be positioned on their right side for 2 hours and have complete bed rest for 6 to 8 hours because of hemorrhage. And hemorrhage is a major complication along with damage to the kidney, to the lung, to the colon, and the gallbladder. There can also become a bile-peritonitis, and symptoms of that include severe abdominal pain. So nursing diagnoses for liver transplantation include risk for infection, imbalanced nutrition less than body requirements, deficient fluid volume, disturbed body image, anxiety, and deficient knowledge. And so I hope you learned a little bit about liver transplantation.